welcome to this one-off session with the General Medical Council of the Health and Social Care Select Committee. I'd like to start by welcoming our witnesses. Thank you so much for sparing the time today. Can we start by you introducing yourselves and your roles, please, starting with Charlie Massey.
Sure. I'm Charlie Massey. I'm the Chief Executive and Registrar at the GMC.
Hi, good afternoon. I'm Anthony Umo. I am General Counsel and Director of Fitness Practice at the GMC.
Well, thank you very, very much, as I said, for coming. Today we are aiming to roam across a whole host of issues, but it might perhaps not surprise you to know that we're going to start with physician associates and anaesthetic associates simply because of the controversy over the last few years. So I want to start by asking a little bit of a retrospective question, just to understand a bit better how we've got to where we are now. Your stated aim on your website, which I checked this morning, is to support good, safe patient care. Yet much of the controversy around this has been centred around that exact issue. What kind of risk assessment was done when you decided to take this on whether this would undermine your centred aim? Charlie.
So thank you. So it had been quite a long-standing ambition of various governments to both kind of change our legislation, but also to think about bringing these roles.
Yeah, they'd been around for a while. It needed regulating.
And I think sort of, you know, at the heart of your question is really kind of taking a step back. What was the aim of regulation? The aim of regulation was to say, here are a group of healthcare professionals who are currently not regulated. And regulation helps patients, employers and colleagues realise that PAs and AAs are safe to practice and indeed that they can be held to account if serious concerns are raised. To your question about kind of what assessment was made of some of the concerns that arose, at the time that government consulted around regulation for PAs and AAs, none of those concerns were raised. And it was really only in the aftermath of the previous government's long-term workforce plan where there were some ambitions to significantly increase the number of PAs and AAs in the system that there began to be concerns expressed from some quarters. And those concerns really were, to what degree will PAs and AAs lead to a blurring of the boundaries between the role of a doctor and the role of PAs and AAs? There were concerns around scope of practice and whether or not there should be a tightening of that scope of practice, particularly because there were some tragic stories about where patients, particularly Emily Chesterton, had lost her life being treated by a PA. And I think there were also concerns which linked, I think, to the prevailing industrial unrest at the time in terms of industrial action by resident doctors about the degree to which PAs and AAs might impact on training opportunities for doctors. Yeah. But I think it's worth saying that all of those concerns emerged after the government consultation. But are you seriously saying
they weren't foreseeable from, I mean, the GMC is you know, full of very knowledgeable people who understand this space, and your primary stated aim is about good, safe patient care. Yeah. I mean, are you seriously saying that, I understand if other people were late to this party, I understand that, but this was a direct ask from government to you. I mean, did you feel you could say no? Did anyone consider saying no?
So it was a decision by my council to say that we would say yes when we were asked by government. We were very clear.
But at that point, did no one do a pros and cons list?
Yeah,
it's kind of basic, right? At a board level.
We did. I haven't got the paperwork to hand.
Could you send it to us?
We would. I'm sure we can. Yes, we will have had a council conversation. We did have a council conversation saying government is going to ask us to take on the regulation of these groups. You know, are we prepared to do that? We were very clear at the time. We would be prepared to do it if government funded the setup costs, because we need to be really clear that we weren't funding the regulation of PAs and AAs through the licence fees we collected from doctors. That would be the wrong thing to do. Some of the issues I described about blurring of boundaries and workforce expansion, those weren't issues that belonged to the GMC, really. So the anxieties about PAs being grown to substitute for doctors' roles was really an anxiety that was aimed more at government. But the problem we had at the GMC was that the GMC at the time was the only game in town in terms of the organisation that was being asked by government and by Parliament ultimately to take on the regulation these roles. But I think where we...
But it's also kind of not your problem. If you look at what the government's asking you to do, you are an independent body funded by fees and not by government, right? So therefore, you could have said no, and you chose to say yes.
Yeah.
And so what I'm trying to get to, and I appreciate you might want to write to me about this, but
Sure.
I just don't fully accept that you couldn't have seen some of this coming,
well,
and therefore avoided some of the issues that you've seen.
So we did say yes, and part of the reason we said yes is because PAs and AAs in their work within the medical model, and they work alongside doctors. So and some of those issues around training opportunities we did anticipate, and our view, which I would maintain now, was that the best way to ensure that doctors' training opportunities weren't adversely affected by PAs and AAs was to have the same regulator responsible for regulating both groups. So that was a very explicit part of the conversations that we had when we were agreeing to take that on from government. So I wouldn't want the committee to reach a view that these weren't issues that we thought about, discussed, considered, but we decided, my council decided that we would say yes, and I think that's a decision that they would stand by now.
Okay, I would definitely appreciate seeing papers from the time, just so we can better understand what was going through the minds of people. So let's come to the present day, sort of. So since then we've had the Leng review, which has obviously, in terms of implementation, been held up by various court cases. Can I understand, I was trawling through your website this morning, you are still using the old nomenclature. Government isn't, though. Government's using the new assistance nomenclature and then saying who are legally known as until these cases are resolved. Can you explain why are you still using the old nomenclature?
Because the regulation of PAs and AAs is set by Parliament, and the order that we operate under is the Physician Associates and Anaesthesia Associates order. And we took the view that there would be quite considerable confusion by adopting new titles that weren't the titles that were set in legislation. Now, we've been very clear to government, and government, I think, are determined to change the law, to change, because the title needs to be changed in law. So we're expecting government to consult within the coming weeks on legislation that will both make that name change for PAs and AAs, but will also modernise, which I'm sure we may come on to a bit later. So in the meantime, we are making sure that we're clear about where we need to change all of that. As you'll appreciate, we have literally thousands of web pages and things on our website. We have registers that relate to physician associates and anaesthesia associates, so it's not a trivial task in terms of changing all of that.
But just if I can just as a premise, though, you also accept fully the recommendations in the Leng review and are preparing to implement them in full. Is that fair?
Yes. So we welcomed the Leng review when it was published last July, and we will be taking forward those recommendations that relate to us. I think, as you alluded to earlier, the fact that there have been some legal challenges subsequently.
Are they over? I mean, my understanding. No. So what's ongoing, just so that we're clear?
So the Union of Medical Associate Professionals has, I'm not sure about the exact status, but they launched prejudicial review proceedings in the summer, understandably because they were anxious that their members would be losing their jobs in the very immediate term. And that, I think, has had the effect of slightly slowing things down in terms of using the Leng review as a bit of a reset moment, which is what I had hoped it would be, because I think whilst there's been considerable and genuine anxiety from a number of doctors about the PA and AA set of issues and the Leng review, that there's also been genuine anxieties and concerns expressed by members of the PA and AA community, and of course I hear a lot of those firsthand, and some of the behaviours that people have been subject to have been completely unacceptable.
They've been let down too.
Everybody's been let down, and I think obviously our job is to regulate those PAs and AAs that there are. We've got about 4,000 of them now on our register. The vast bulk of those are PAs, not AAs. And my hope, and this is a point I've made to government, is that the 10-year workforce plan, when that's published in the spring, will set out a bit more clarity from government about these roles and about kind of multidisciplinary roles more generally. as part of those workforce plans. I'm not expecting government to set out specific numbers in terms of expansion of that workforce. I think that's highly unlikely given what happened before. But I am hopeful that the workforce plan will also help to reset things and enable people to move forward in a way where there is courtesy being extended to all members of our healthcare professions.
And the reason I started with the nomenclature, I mean, it felt like it was the easiest thing for you to change on the website to show that you are resetting, moving on. So I appreciate the explanation, but do you understand from the points of view of the doctors who are looking with interest at what's happening, how that feels like you might be dragging your feet? So what I'm trying to do now is get a better steer about how ready are you for December 26th. You've explained the name change thing. And the Leng Review is very clear about the bits that you are responsible for. So if you wouldn't mind, I'm going to go through each one, and very briefly, if you could just tell me where you've got to with this, and if any of these are on your risk register for not getting to the right place by December 26th when we get that deadline. So we've done the name change, you've explained that, although I'm sure there will be many watching who would urge you perhaps to take the approach that government has. Where are we with the curriculum and training changes and the relationship with the Royal Colleges?
Yeah, so we've been talking to Royal Colleges and also the PA Schools Council. I met the PA Schools Council in August. We're not actually sure that there is a need to change issues in the PA curriculum to take account of the Leng recommendations, and certainly that's been part of the preliminary conversation we've had. The question we've been talking about with them has been the recommendations about not seeing undifferentiated patients, to what degree might that need to be reflected in the curricula. But we actually think the curricula would still be wanting PAs and As, even in a world where they are seeing differentiated patients, for them to look at the totality of the patient in front of them and be able to use the kind of the wide set of diagnostic kind of skills and experiences that they would have been built up through their education. So that's a kind of work in progress, but we've been having those conversations with the PA Schools Council. I think at the moment our view is that probably doesn't need to be any significant change to curricula on the back of it.
Interesting. And you mentioned the whole undifferentiated patients. I mean, this was really the nub of the issue, wasn't it? Particularly with the PA's issue, is the worry that someone's going to present at a GP surgery with a cough, and it actually is something much more nefarious than that. And the worry, I mean, the Leng Review makes very clear that evidence shows very strongly that it is that sort of almost intuition that you develop by long-standing practice and study that even novice doctors have, that PAs just don't, and it's that first diagnosis that can be the most concerning. Are you confident now, and are you with the Royal Colleges very confident that is bottomed out and that risk is now mitigated as a result of what's going to come?
So I
because
think
if there's no changes that you're going to make, then how is it? How are these risks going to be better mitigated?
So the question around differentiation is really a matter for employers and how they deploy PAs and the way in which doctors in their supervisory role of PAs operate. So some of the issues that we've seen in terms of PA practice have been partly about PAs seeing undifferentiated patients, but also about the clinical governance environments in which they have been working.
I was going to come to supervision because that's the other side.
Yeah, because I don't think that's always worked as well as we might have wanted it to, and I think many employers have been working really well in terms of making sure that PAs are working in appropriate clinical governance environments, but not all have, and I think so.
So where is the GMC? Where specifically is the GMC role in that? I mean, you're the regulator of it, so presumably you've got a line. At some point, if someone isn't doing it properly, you then have the ability to go, you're not doing that right. So you've got that somewhere. Where is that going to be written down? How are you going to get that across so everyone's working from the same hymn sheet? So
part of that is around work that we are still doing around how do we think about the clinical governance that we're expecting from PAs and AAs as they land in practice.
I mean, AAs is easier, right? In the Leng Review, it's clear. Yeah, it's one-to-one, and then 2 years later, at that point, there's a conversation. Yes, PAs, it's not as clear, is it?
So I think some of the same issues apply for both, actually. Okay. So for doctors, for example, we have revalidation. And revalidation is a mechanism through which doctors every 5 years need to be able to demonstrate that they are up to date and fit to practice, and that the scope of their work fits their knowledge and skills, recognising that people's knowledge and skills changes through their career. And revalidation is supported by appraisal. And we will introduce something very similar to that regime for PAs and AAs. It has to be a little bit different because we don't have the same underlying clinical governance architecture. We don't have responsible officers for PAs and AAs as we do for doctors. But those questions about how do we spot whether PAs are being deployed appropriately in terms of differentiation is really part of the kind of the clinical governance expectations that we set, part of what we police through the relationships that we have with medical directors, who ultimately will be responsible for those clinical governance environments, including for PAs and AAs. And of course, we will be setting clarity through the curriculum that we've talked about already in terms of what PAs and AAs know they should be thinking about in terms of where their practice begins and ends. Good medical practice that we produce sets out the standards for PAs, AAs and doctors around people exercising their professional judgment in terms of what they should or should not be doing. And then finally we have the backstop of our fitness to practice processes. So Anthony and his team will take referrals, whether they're from the public or from doctors or from organisations, where there are concerns that something hasn't happened as it should have happened, and those issues are always considered on their own individual merits when we get them. So there are a variety of ways into that, and all of those kind of relate to your question. Are you considering
doing some sort of a best practice guide almost? This is what we're aiming for. This is a gold standard. I mean, this is what I've been hearing from a number of different sources. It would be helpful to understand. Is a phone call sufficient at this point in someone's training? Is the expectation that they should be able to have access to their supervisor in real time, or is once a month check-in sufficient? I mean, all of these things could legitimately be considered supervision. That's what I'm trying to understand.
Yeah, so
in practice, what will it mean for a patient who's wondering, am I safe or not?
So I think this is where it becomes quite complicated.
Yes, that's why.
Because we have PAs and AAs working in a very wide variety of different clinical settings. So what
Can we just take one? Let's just take one. The GP surgery, which some identify as potentially, this is why they're going to be not allowed to work in those community settings for a couple of years, or indeed mental health, according to the Lang review. So that's the slightly higher risk end of the spectrum. What's your view in the GP surgery setting? What's best practice for that, according to the GMC?
So for general practice, as with emergency medicine, as with surgery, what we would look to is the Royal Colleges to hold that expertise in determining issues relating to scope of practice and what is or is not permissible. At the GMC, I don't want to suggest that we have the clinical expertise in every single specialty to be able to define at a level of detail. That would be also disproportionate for us to do that for a group who at the moment are numbering 4,000 overall. So we've always been really clear, and you'll know that we were legally challenged around scope of practice.
Yes.
That we won't do that for PAs and AAs, we don't do that for doctors either. And we look to the Royal Colleges and specialist faculties for their expertise in terms of that precise detail about what should a PA working within a primary care setting.
So would you expect the supervision bit of it, in my example of GPs, to be covered by the Royal College of GPs, and they will say, this is what good supervision looks like, therefore this is what you do?
Yes.
Because there's going to be a separate body that's going to be looking at PAs. So which college gets which bit?
Yeah, so on the supervision, I mean, we're very clear that PAs and AAs work under the supervision of doctors, and obviously the specialty they work within will determine which doctors they work under the supervision of. Employers are responsible for deploying PAs and AAs appropriately. They're also responsible for ensuring that they have proper and effective supervision. One of the other concerns that's been raised around supervision is if something goes wrong, what's the doctor accountability? And again, we've been really clear, and there's material that we put on our ethical hub around the supervision of PAs specifically, that doctors are not accountable for the actions and decisions of PAs and AAs, provided that they've delegated responsibility to them in line with our guidance.
Yep.
So we've tried to be as clear as we can be, but as I was saying earlier in relation to the general practice example, we have to be somewhat generic in the way in which we set out,
yes,
these are your responsibilities in
principles-based.
terms of providing supervision.
Understood. On the good medical practice, you'll know there is an active debate, or perhaps not active, insofar as there seems to be a real push from doctors to have a separate guide for PAs and AAs, so that it is clear. And the Leng Review basically says it should be differentiated and more clear. And I did read it this morning. It is absolutely not at all clear as it currently stands. The end product, which I assume is going to be published December this year, is that what you're aiming for? Or are you aiming to publish a new one sooner? What's the deadline for?
So I can't give. I don't know the exact deadline. We're working on all of our material. So
are we working on one? Basically, is it going to be one or two documents?
So it will be one document. So we got legally challenged about whether there should be separate documents for doctors, PAs, and AAs. And that was a claim brought against us by the BMA, and it went to the High Court, and the High Court dismissed that BMA claim on all counts. And the reason for that is because good medical practice relates to the standards and values. It's not a scope of practice document. It's about standards, values, and behaviours that we expect. What the Leng Review also said, though, was we should be clearer in differentiating on our website and through some of the materials associated with good medical practice about where that relates to PAs, AAs and doctors, and we are in the process of doing that as we speak. We have already updated a number of bits of guidance on our public-facing materials, and we are continuing that work. Obviously, some of this relates back to the earlier point we were talking about in terms of name change, because, as I said earlier, we have thousands of pages, hundreds of different guidance documents that we need to update, and that's not a trivial task. And I want to make sure that when we do that well and we do it properly. So that is exactly the process that we're currently embarked on. And then very finally, management training is built into curricula. Where are we with that? So yes, so that's again part of the conversation we've been having with the PA Schools Council. Actually, quite a lot of that is already built into curricula. But that's more about the doctors, isn't it? That's not sorry, yes. So there are bits about that in relation to PA and AA curricula, and in terms of doctors, we do build that into doctors' curricula, but there's also some specific guidance that we produce around management and leadership, and that's the piece that's currently being updated at the moment. And so out of 100, how confident are you that all of this will get done by December? So I'm absolutely confident that we will deliver all of the recommendations that we're responsible for that came out of the Leng Review. I've met Jill Leng myself on a number of occasions, and I've given her that assurance directly herself. There are a number of things that still remain unresolved in terms of implementation, and those aren't issues that the GMC owns, but they are issues where we have given our commitment to work with Professor Leng and with her review team and with government to make sure those are all taken forward. Thank you very much for that update. Over to Andrew George, please.
In terms of nuts and bolts, just going back to nuts and bolts, you're halfway through the transition period of registration. How is that going? Do you know what the population that are likely to register, what proportion have registered so far?
So far we've registered, so this is as of the end of December, about 3,900 PAs and nearly 200 AAs. We think that accounts for the majority of those who are out there in practice at the moment. And the reason for that is because there is an incentive for PAs and AAs to have registration with us. Indeed, in advance of all the controversy that we talked about earlier, PAs and AAs were one of the groups that really wanted to be regulated by the GMC, because by being regulated, it gives them status and it makes employers feel safe about employing them. So you know, PAs and AAs have still felt incentivized to be registered with us. I'd say that accounts for the vast bulk of PAs and AAs out there in practice. I can't give you the exact number because we don't know how many aren't registered with us. It's one of those kind of unknown unknowns. But I would guess that we've probably got upwards of 80% of PAs and AAs who are in practice already registered with us.
So, but is it really a known unknown? Because someone knows, and those are presumably the employers at the local level, and surely it's not, beyond the wit of any man or woman to corral that that data pretty quickly?
Yeah, I absolutely understand the point you're making. I don't think the data actually enables us to interrogate it in quite the way that you suggest. But I don't think there's a problem there. I don't think there is an issue with PAs and AAs not being registered with us who are out there in practice. As you said, we're halfway through, so by December this year, in order to be able to practice as a PA or AA, you must be registered with the GMC, and it's that date that's also driving some of the legislative timetables for the Department of Health in terms of the name change that we were talking about earlier.
Yeah. I mean, if that's the case, then there's no need for delay, is there really? I mean, if you think the majority are registered, then presumably the nomenclature issue, and there's no reason why you can't start.
Oh, we already have. So as soon as you register, you are regulated by us. So we already have, for example, PAs and AAs where concerns have been raised with Anthony's team in relation to not very many, but as soon as you're registered, the full panoply of regulation applies. We're also already regulating PA and AA courses, so we have to approve those courses, and indeed we haven't always done that, and we've applied some conditions to some courses, and one could argue that that's actually a really good argument for the benefits that regulation brings, because where we've been concerned about for example, the breadth of the kind of clinical placement experience that's being offered by a course, that we're able to step in and say you need to get better at that if you're going to be able to maintain your registration.
There's nothing stopping you, but you're saying in law that you can't.
The thing that governs our law is the physician associate and anaesthesia associate order. Yeah.
Absolutely.
Yeah.
And then in terms of parallels with the nursing profession, I mean, how do you think that's proceeding? How do you share notes?
We do, and I think, nursing associates have been around for some time. There wasn't the same degree of controversy around nursing associates as there has been with physician associates. I think there has been perhaps a bit of a wider debate on the back of some of the concerns that were expressed with PAs and AAs that have begun to get into anxiety about other roles and substitution. So there is a generalised level of anxiety, whether from doctors or from nurses, about other professional roles being used increasingly to take roles from other professionals. And I think this is a really tricky area, because practice is always evolving, whether you're a doctor or a nurse. There are things that only doctors could do 20 or 30 years ago that a range of healthcare professionals can do now. So
pressures to find intermediate people on lower salaries to undertake the functions which a higher paid person were undertaking before. You mentioned that you mentioned anxiety, you mentioned controversy. To what extent do you think the GMC has a role in quelling or resolving the controversies and the anxieties within the profession itself? Do you think you have a role at all, or are you simply an observer that is standing outside that?
We're not simply an observer. But equally, we don't hold all of the levers that the things that people have anxieties about. So we do see ourselves in having a role, which is why I said earlier we hoped that the Lang review would help to reset the narrative. I think it became very toxic, and I think there were genuine anxieties on all sides. For our part, we've tried to be really clear that we, for example, take training of resident doctors. We have some really important roles in terms of overseeing the quality of postgraduate training environments. Those are roles that we take really seriously. We advocate very much, and it's part of an ongoing conversation with the government about the workforce plan, about ensuring that formal postgraduate training is of high quality as possible. And you may have seen we're not afraid to take action and put trusts into enhanced monitoring where we don't feel those things are happening. So we have a role in getting that message out that actually we are here to protect doctors' training and ensure that it is of high quality as it can possibly be. But equally, those questions about substitution, ambitions about workforce growth, skills mix, those aren't questions that belong to the GMC. Those are questions that are for government to answer. And I think, I hope that the long-term workforce plan will begin to set out a clearer story about government's position on all of that.
responsibility to ensure patient safety. That's fundamental to your purpose. And surely that it's your role to both inform the government and to respond back to NHS providers in circumstances where patients are being put at danger as a result of decisions about the skill mix and the staffing levels that are operating within those environments. Surely that is your role.
So yes, and you'll appreciate that there are a number of conversations we're part of behind the scenes in terms of trying to make sure that government policy is properly informed by the evidence base that we can bring. You know, one of the things that we've put a huge amount of investment in at the GMC over the last decade or so has been our data and analysis, because that does help exactly with your question about ensuring that when government are making policies, whether to address bottlenecks in postgraduate training or thinking about skills mix, that we're bringing some evidence into those conversations. We will do much of that behind closed doors. We don't see ourselves as an organisation that should occupy a kind of shrill lobbying position, because we want to bring real objectivity to the points that we're making.
But part of the evidence base is the controversy and the anxiety and the turf wars that have been going on between professions within, for which you as the GMC are responsible for regulating, and therefore surely that is very much the focus of your responsibility.
Yeah. And I think what I was saying was those are exactly the sorts of conversations we have been in, but we won't necessarily be publishing and publicising every detail of every conversation.
To reassure us that you are having those conversations, and you're not just saying there are conversations behind closed doors, and we're supposed to just imagine what those conversations are.
So we know for some time the government has been thinking about what its next long-term workforce plan should say, and we have been talking in great detail about some of the things on our wish list and things that we think need to happen within that. So to give you a very concrete example, we believe that there needs to be greater capacity and investment in the educator and trainer workforce, both for doctors and for PAs and AAs, because we can see in our data that educators and trainers, whilst they take a huge amount of pride in their jobs, are feeling more burnt out and under heavier workloads than many others. They often don't have their training responsibilities clearly set out within their job plan, so they don't feel valued. And so part of the conversations we then have with the department is, so how do you do that, and how do you help employers feel incentivised to build that workforce, and also think about the education that can be provided to the non-formal training workforce as well.
That's happened on your watch, and there is still the controversy and the anxiety there. So don't you think you owe it to the industry, to those who are regulated by you, to both acknowledge the fact that perhaps you could have done more, and to apologise to them and to say that you have a role in repairing those relationships going forward?
And I think I've said earlier that I do believe we have a role in reset, but I don't believe we own all of the levers that have caused some of the anxiety. So we definitely have a role. And
for Are You Sorry?
I would love if I could turn the clock back to sort of said, actually, how can we be even clearer in distinguishing between PAs and AAs?
You itself says, how do we make sure this doesn't happen again? Yeah. So, I mean, I would say even in the review, it puts to you and everyone in part of the system, you aren't the only one, we fully understand how this knits together, but for your part, are you sorry?
So I'm sorry with the benefit of hindsight that we weren't clearer about distinguishing between those. We did make a decision to have different reference numbers for PAs and AAs than doctors, but we could, and with the benefit of hindsight, should have gone further in terms of that differentiation than we did. But I think in terms of actually the getting regulation up and running, I'm really proud of the team at the GMC for doing a really excellent job. It was a really difficult and big job under very difficult circumstances, and all of my colleagues at the GMC were utterly professional, despite being on the receiving end sometimes of some pretty unprofessional behaviours themselves. And I need to put it on record that I do believe my team did a really excellent job and continue to do an excellent job in that task that we've been asked by Parliament to take on.
moving on, though, to the legislation under which you operate. I mean, you've described it as antiquated, and certainly you're running kind of two parallels kind of frameworks at the moment. And the government has acknowledged, certainly the previous government, I believe the present one, saying that it is unacceptable that the GMC can appeal against the conclusions of a tribunal, for example. So all of that needs to be brought up to speed, modernised and made more effective. I mean, in your risk register, you're indicating that you're concerned about the extent to which that is likely to be brought forward, and to be brought forward in a manner that is of sufficient quality to give you confidence that you can go forward with governance instruments that will be fit for purpose. Is that right?
So the legislation is quite complicated. We actually, as I speak to you now, we have been engaging the department in detail on the drafting of the legislation that they intend to consult on soon, and I think it's in pretty good nick, and government's plan is to consult on that before PERDA periods begin in Scotland and Wales, and in order to get the changes on the statute book by the end of the year, particularly because of that name change piece for PAs and AAs. We have, in fact, not just us, I mean, the Law Commission back in 2014 described the existing legislation as fragmented, inconsistent, poorly understood, cumbersome and expensive, and I would agree with all of that. I mean, the legislation that we operate under is highly prescriptive, it's over 40 years old, and it means that we aren't able to resolve fitness to practice cases as swiftly as we would like. It means that we can't avoid unnecessary adversarial tribunals as often as we would like. And as a result, it chews up resource that we'd rather be putting into more of our upstream activity to support doctors and essentially enable doctors to be great doctors before they get into trouble. The right of appeal that you described is something that we've been operating for about 10 years. I think the Williams review was the review that suggested that our right of appeal should be taken away. We're reconciled to that. The Williams review did say that we have always used our right of appeal proportionately and appropriately, and I think the numbers bear that out. We've been successful in about 3/4 of the appeals that we've taken. But as I say, you know, part of the government's plan is to take that away, which is fine, and we will therefore make sure that if there were cases that we would have wanted to appeal, we'll make sure that our regulators, the PSA, are aware of our views on those cases.
You want a regulatory environment which gives you greater flexibility, and certainly there seems to be an environment in which you're either exonerated or publicly hung and flogged, and there seems to be no kind of in-between way of kind of resolving issues so that you're supporting doctors. I mean, how would you see that being delivered?
So the changes that we will get through the legislation will give us more discretion about deciding which fitness to practice cases we decide to take on. It will give us much more discretion in how we conclude those cases, so we'll be able to conclude cases more quickly than we could before. It will give us a power to come to an accepted outcome. So where there has been a fitness to practice concern about a doctor, and we and the doctor can agree to erasure or suspension or conditions, we can do that without going through a tribunal process, which is also good for any patients or others involved, because it is an adversarial process. It will give us more targeted and focused powers in our quality assurance role of education and training. And it will also create new duties of transparency and accountability. So I think there are lots of things in there that we think we will be able to benefit both doctors and patients from.
Just one final one on this, which is that in your risk register, the risk of omission and the risk of delay and admission is one which is given kind of the red rag, as it were. I mean, what types of errors or omissions you concern may be made, and how is the department responded to your concerns?
So it's about getting the legislation right. And as I said, it's complicated. Because we're a professional regulator, we are a fairly risk-averse organisation. We don't want to do things that get us into a position where we're not taking appropriate action, where we should do, particularly in terms of fitness to practice. So therefore, a process that fundamentally rewrites all of our rules and processes about those core operational functions is one that we must get right. And therefore, where there is a process of legislative drafting that is going more to the wire than we might ideally want, that raises concerns with us about risk. And that's what you're seeing reflected in the risk register that you're quoting.
Thank you very much. Can you just tell me how many people are employed by the GMC?
Gosh, I haven't got an immediate number at my fingertips. About 1,800, I think, is roughly speaking.
About 1,800. And do you know how many were employed at the sort of start of the last government in about 2010?
I don't off the top of my head, no.
Okay. And to the nearest 100?
Probably about 1,000 would be a guess, but it is a guess. I'd have to come back to you with any.
So the figures from your report are 605. So why, in those 14 years, has your staffing ballooned to 280%, nearly 300%?
So I don't know if you've got them in front of you, but the number of doctors that we register has gone up entirely proportionately with the volume of staff that we have.
Sorry, are you saying that the number of doctors you register has gone up by nearly 300%?
So I think when I started this job, we had about half as many doctors registered as we do now.
Right, so a 50% increase.
Well, I started this job in 2016. I think you were quoting numbers from 2010. So I
my
haven't got the
understanding
2010.
is the doctors' numbers have gone up around about 50%. Your staffing numbers have gone up by over to nearly 300%. I'm just kind of deciding whether this is an efficient regulator. And on those very basic numbers, and I accept they are basic, I would suggest it doesn't seem very efficient.
Well, I do think there will have been an increase in the doctor population between 2010 and 2016, but I can come back to you with the precise numbers on all of that. We have also, as we've just been describing, taking on regulation of a new profession, which has involved a lot of kind of resource, which has been funded, as I said earlier, from government in terms of taking on the regulation of PAs and AAs. We have always been very diligent about thinking about the licence fee we charge for doctors. So we have one of the very first things I did when I arrived as chief executive was to actually put in place a fee freeze for a year. But other than that, we have kept fees, certainly whilst I've been at the GMC, in line with inflation. So we haven't been increasing our cost base more than inflation, which I think is probably the most important measure.
Okay, so one of the areas that you don't appear to have a grip on is doctors who are subject to regulatory action overseas. And obviously there was a big report in the Times at the back end of last year where significant numbers of doctors who are registered with you had received overseas actions and you weren't aware of them. I understand that you started to put some processes in place. I'd like to just probe that a bit further and understand what actions you've taken to, one, deal with the problem and in and of itself, but also what steps you've gone to go back and check that there are no others who you've missed.
So we've worked at pace to review. We've reviewed each of the cases provided to us by the Times, and we've taken action. So we've, in a number of cases, held interim order tribunals where we've been able to suspend or place conditions on doctors' practice. We've added an alert to the record of each doctor that was defined by the Times as well. In our processes, generally, we do very significant checks in relation to a doctor's employment and registration history before they join our register. And that means that we kind of ask for their kind of employment history, certificates of good standing from regulators overseas. What is quite interesting in terms of the Times piece is that amongst those doctors that we weren't aware of, where there had been sanctions overseas, in the vast majority of those were doctors who had already joined our register and maintained dual registration in another country overseas. Now, we're really clear in all of our requirements of doctors about their responsibility to disclose information to us about sanctions or convictions overseas, and we've tightened our expectations and the wording we've placed around that with doctors. But it's also worth saying we are reliant on regulators overseas in disclosing that information with us. And this is an imperfect system. Not all regulators are willing or able to share that information with us. I have nonetheless been very ambitious about trying to get that information. So I've written to regulators worldwide. I've also written to government ministers asking them to make access to the European Internal Market Information System part of their trade negotiations with the European Commission. So going back just over a decade, the GMC was essentially the organisation that drove the creation of the IMI system that led to better information sharing between European healthcare regulators, and we lost access to that after Brexit. But we do continue to proactively share information, but not all regulators are prepared to share that back.
Could you just give me a flavour of the overseas regulators who are not sharing the information with you?
So we've written, some of them just simply don't really engage. Others have said that it's too much of an administrative burden to provide that information. Others have said that's fine so long as you write to us and we will react to that on a monthly basis.
Sorry, when I said flavour, I meant can you give me the countries in which do you have a list of those regulators not sharing their information?
So I can
create one if you don't have it.
Some of this is a work in progress because obviously some of these conversations are live with regulators. But for example, I think it is. I'm conscious I don't want to create a diplomatic incident, as I believe has happened from one of these sessions that GMC attended in the past. But I believe Finland said that they wouldn't be able to do it because of the administrative burden it would create.
So I think the chairman, I think it would be useful to have a list of all those who are currently not, for whatever reason, sharing that data with you. Given that, do you, and obviously patient safety being your priority, do you think it's acceptable to continue to register doctors who are dual registered in those countries that do not provide that information to you?
So the problem is we don't know we don't know what we don't know. So a doctor could be registered in another country that we don't know about, and so that's part of the problem. Now,
so could you, given I understand the limits on what you know and what you don't know, but part of your guidance or requirements that a doctor must tell you if they are registered with another regulator. Is that something that's listed in your rules at the moment?
No, we are very clear, and we've made the wording even clearer to doctors about their responsibilities to disclose that information with us.
Do you know if they're registered with another regulator
in another country? We know what the doctors have told us. I think my point is, in answer to your question, we don't know if doctors have not told us, even though we are being clear to doctors that they must tell us if those things exist, and that's why we're looking at other steps that we can take. So as well as writing to regulators worldwide, we're also engaging with IAMRA, which is the international, I forget exactly what each of those, International Association of Medical Regulatory Authorities, I think is the precise acronym spelt out, about how they can support us with all of that. There's a kind of other federation of state boards that tries to corral information from overseas regulators. So we are pulling every lever we possibly can to get that information. We're also pulling every lever we can to tell doctors of their responsibilities to us. And we're also considering what else we can do. So, for example, can we use AI in a more intelligent way to do more trawling of the internet to find more information about doctors, whether they may have sanctions or convictions overseas? But even that's not straightforward because there may be many Dr. Smiths or equivalents in different countries worldwide. There'll be hundreds of different languages to navigate. So this is difficult stuff. We are absolutely clear about our desire to really get on top of it, and I think, indeed, I do
accept it's difficult stuff, but the Times managed it, and if they can manage it, shouldn't we be on the wit of the medical regulator to manage it?
Yeah, and I think on the back of the Times piece, we've asked ourselves exactly those questions, which is why we're doing all the things we are. But I mean, it's worth saying, I mean, the PSA, the Professional Standards Authority, our regulator, looked very closely at this as part of their assessment of our role in regulation, and they said we recognise the swift and thorough action taken by the GMC to restrict the practice of the doctors concerned. But they also say it's still an area of risk. So yeah, and I don't disagree with that at all. And what the PSA said is we should be considering whether or not we should be looking for longer employment and regulatory histories, and those are exactly the things that we're doing. This was a so this was a story that broke in through October, November.
No, you're looking at doing these changes.
So we're looking at all of those.
We're
looking at all of those right now, and we have been since the moment those time stories changed. We've done things since the time story. So the issues around strengthening language on our website, implementing further checks with the Federation of State Medical Boards, exploring the use of AI tools. Those are all things we have been actively doing.
Right.
But I'm not in the least bit complacent here. I think it would be wrong for me to say we will have nailed this by March or April, because I don't think this is something that we're ever going to stop asking ourselves difficult questions about how do we get better and more assurance about these issues. I think it's a fundamental part of our job, recognising that we work within a global system where not all regulators share information in the way in which we would like, and any assistance that this committee can provide to improving that would be
give us
very
the
welcome.
list of regulators, and we'll see what we can do.
Well, it's the list of regulators, but it's also that IMI piece I talked about earlier, because actually it was a loss to us not having that access to the European regulatory information. And whilst we will still proactively share all of our information, that is not something that we're getting back in the same way.
It's very helpful.
I just want to confirm, because you slightly answered it there, you share registration and fitness to practice with all the other regulators?
Yes, we do.
And is that proactively or if they ask?
It's proactive.
Okay. And finally, on the 90, I think it was, or the 92, were there any, was there any correlation between them in terms of where they were registered, which countries they were operating in, the types of fitness to practice issues that they've been
I think they were quite varied. So of the 92, 65 of them were doctors we were already aware of. So the 92 whittled down to 27, and there were 8 doctors specifically named in the original Times article against whom we've taken action. And of the 27, I think all but 2 or 3 were doctors who had already registered with us when those sanctions and convictions arose. So that is a really important part of the ongoing exam question. But in terms of your question about patterns, I don't think we've been able to see particular patterns in relation to those. I don't know, Anthony, is that?
No, they were from various different countries.
Thank you.
Very much. Alex McIntyre.
Thank you very much. Just to declare an interest in the top, in my previous role before I came into this house, I was a lawyer acting for healthcare providers up and down the country, often in relation to misconduct by senior clinicians, and sometimes involving cases that went to the GMC. I won't be referring to any of those cases today, but just to be clear on the record, I don't act for them anymore, but just want to be very clear at the top of that conflict. So just taking a step back for a second, it's a fairly high bar, isn't it, to be referred to the GMC on fitness to practice grounds, wouldn't you say?
Yes. I would. So the GMC operates as a backstop, and it's really important that employers are seen and act as the first line of defence when things go wrong.
So sorry, and how many referrals does the GMC receive from fitness to practice grounds on a yearly basis?
Probably defer to Anthony to take you through the numbers.
So we received, so last year we received over 13,000 concerns, which are, when you say referrals, we get them from different places. Yeah. So 13,000 concerns.
And how many of those cases resulted in a restriction on practice or suspension of duties pending investigation?
You're talking about interim orders?
Yeah.
Right. I don't have precise details, because the challenge we have is the 13,000 received 2025, some of them will work their way through 2026. So I can get you the details.
And if you could write to us on with the details.
Several years, and then we'll start to see the
Because I guess the question is, we'll come on to that. So at the moment we've got the details that I've got in front of us. We have, several cases now that are more than a year old, and the time taken to deal with some of these cases is increasing. That's correct, isn't it?
Not strictly correct, no.
Well, in the last 5 quarters, the number of cases that have been open for more than a year is going up, quarter by quarter.
Yes.
Is that correct?
That's correct.
That's correct. So we've got 13,000 concerns. We've agreed it's a high bar to have a referral to the GMC in the first place. I'd be very interested to know.
So the high bar isn't about the referral to the GMC. The high bar is about the conversion of a referral to an investigation.
Okay.
Because a referral, somebody could refer a doctor to us about something that doesn't need.
How many investigations did you start in the last year?
So, of the 13,500, well, I think we typically investigate about 1,000 doctors a year. Now, they won't necessarily be about the same
roughly
volume.
What percentage of that 1,000 had interim orders placed on their licence to practice?
If I can answer that, not about interim orders, but actually about ultimate fitness to practice decisions, which I think is probably the better.
We can come to that in a moment, but I'm particularly interested in the interim orders for now. Do you have a rough percentage? I appreciate you might not have the specific figures, but anecdotally, even what percentage of those 1,000 that are investigated have interim orders placed on them?
I'd have to come back to you,
Okay.
but I think
because I think the point I'm trying to draw out here is we've got a system where you have 13,000 concerns. I appreciate some of those will be more substantiated than others. 1,000 doctors being investigated a year. Some of them with cases open for, some of these are 156 weeks and above. So that's, longer than 3 years. But actually the percentage of cases that go to interim orders and get kind of suspension on licence is quite low in comparison. So do you think that as a regulator you're reassuring the public that where there are consultants who are potentially at risk to patients, that they are being, or any medical professional, I've used consultants there because that was the world I used to live in, but there's a medical professional where there's a concern. Do you think that your role as a regulator, you're reassuring the public that those people are being dealt with appropriately?
I think we can. I think, and I will come back to committee with all, because we have annual statistics which breaks this all down, and you can see that. So I think we risk assess every case and every concern we get in, and the decision is then made whether or not to refer it to a tribunal. The independent tribunal will make a decision on whether or not to impose an interim order. We do that in every case. And in those cases where we get the order, that's reviewed and we investigate. In terms of the delay and the length of time taken, what our statistics will show is that in the vast majority of them, they are third-party delays, either where the police are involved or other inquiries ongoing, where we have to wait for them to do what they're doing before we can do it. In each of those cases, we assess whether or not we need to impose an interim order while we wait or while we investigate. So we do that. And I think when you look through the numbers, and it's probably worth putting the numbers together, so that the sort of big 13,000 becomes a relatively small number through the year, and those that go to a tribunal for final hearing, you're in the 300s or less. So actually, through the investigation, and we're always looking at risk to patients, to the public, and to public confidence, we make those assessments as we go along. At any stage, we can refer to the interim orders. So it's not quite a direct.
I think we'd be really interested to see the data on where there are third parties involved, the numbers of that, and who's responsible. Because we'd be very happy to take that up with other third parties. Because I guess the numbers I've got in front of me here is there are currently 706. Well, this is at Q2 24-25. 760 cases that have been open for more than a year. Now, my concern is, and we've established that 1,000 cases a year, that's a high bar. That's generally medical professionals where there are clear concerns. A lot of them are continuing to practice while they are, under investigation. I appreciate you're saying there are risk assessments done. I can say, with some professional experience, that some of them are, questioned at a hospital provider level, but would you say that any system where we have 760 doctors that are, waiting for more than a year, whether they have suspension on their licence or restriction on their licence, or just waiting for an investigation, is that good for our workforce? Is that good for the system?
So I think no is the short answer, but in part it relates to what Charlie was describing. So if you, and you probably do know this, if you take a case under our current legislation, there is an inbuilt, at least 6 months delay by which we have to back and forth before we can get to any decision. The vast majority of our investigations are concluded within 6 months. But those cases where we can't because of third-party involvement or where we're waiting for information, they go longer. And it is regrettable, and that's part of what Charlie's saying. With regulatory reform, we are hoping to be able to short-circuit some of that. There's also something around the cases we receive where they're not ready to proceed in the sense that there's an ongoing trust investigation or NHSE investigation where, again, we don't have the information, they won't give it to us till they complete what they're doing. So in the vast majority of those cases that go 12 months
presumably, though, we can't have a situation where we've got serious concerns about a clinician who, and we know in the modern world, clinicians practice across various different sites, various different times, and there's very little communication at times between, if they're operating at one trust and then, have a private practice elsewhere, still in the UK, and private practices abroad increasingly, where effectively the regulator can say, well, they're still investigating whether they're safe or not. That's nothing to do with us until, surely that's putting the cart before the horse, isn't it?
No, but that's not what we do. So that's where the interim orders come in. So there are two things that happen when we receive a complaint. We assess it for risk. Do we need to impose an interim order? Can it be managed locally? And then we also have our outreach service, which connects the dots you talk about. So our outreach colleagues speak to responsible officers across the private and public sector, and they will connect the dots and make sure that there isn't any holes in our patient safety armoury. So it's not about us saying they're investigating, we'll leave it. The risk assessment happens once we have seized of the information.
Okay. Moving on to kind of the other side of the coin, I still think there's a lot of concerns about, if the general public were aware of some of the delays in this, I think they'd be really quite concerned that these things aren't being dealt with quickly. Moving on to the other side of it, I'm really conscious of the well-being of doctors here who are waiting. On these numbers, 180 people have been waiting for 3 years or above to find out whether they're going to be able to continue their livelihoods or not. That's clearly not acceptable. And what are the GMC doing to try and support those doctors or signpost them to support? And where their ability to practice is restricted, what steps are you taking to ensure that they can get the reskilling and retraining they'll need to get back into the workplace?
So again, we will only restrict where there's a need to restrict. So if you are restricted, then to your first point, it means that there's a risk to the public that can't be managed locally. So if you are restricted, again, there's an inbuilt check. Every 6 months, that order is reviewed to make sure it is still appropriate. We also then work with local employers, if you're on conditions, for example, or restrictions on your license, to make sure that you have the support to practice within those restrictions and get that retraining. So we do that. I think in terms of your point about delay and people waiting, as I said, there are a range of reasons why these cases are taking down. In some cases, it's because a practitioner cannot deal with the hearing themselves, for example, when they're unwell, and we have to wait for them to get better to do it. In other cases, it's third-party delays that are causing it, be it the police or other inquiries. So a range of factors affect our ability. I agree with you on the general point. We would rather deal with these things as quickly as possible. We'd rather not deal with some of it and let employers deal with it. So I don't think we disagree, but I think there are reasons behind some of this, and some of it is the legislation we're currently operating under.
I'm very conscious we're about to come to vote, so I'll leave my questioning there. I would very much look forward to seeing the only data you can share with the committee, and I'm sure we can then follow up after.
Right, as suggested, we've had some intel that we are imminent with votes, so I'm at this point going to suspend the sitting.
Can I declare my interest?
Yes, go ahead and declare.
And then we can get that on the record. So just before I get to my questions, I'd just like to declare my interest that I worked for the GMC for 5 years. As an organisation, I found that everyone that worked there was committed to both safe medical regulation, the best for doctors and the best for patients. My questions will primarily be on fitness to practice, which was not an area that I worked on. My career was predominantly around medical training.
Thank you very much. And on that note, we will suspend 3 votes, maximum probably 25 minutes or so. Order. And we resume. Josh Fenton-Glynn.
Thank you very much, Chair. And just to reiterate, I declared my interest before that immediately before becoming an MP. I spent 5 years working for the GMC, although none of my role was around fitness to practice. Last year, I was interested to find out a bit more about how the GMC manages sexual harassment and misconduct claims, and I looked actually at all the regulators on this. I quickly found that the publicly available data is very limited, so I did an exercise where I sifted through individual case reports that were online to get an idea of what was found. And it was in the end, the only option I had was to submit a number of FOI requests, which I'm sure you were briefed about before this meeting. Do you think the GMC could do more to be transparent about the high-level data around fitness to practice, and particularly sexual harassment and misconduct cases?
So it's a good question. I mean, as you know, we're really clear that sexual misconduct is unacceptable, and you'll also know that we've done a lot of work over recent years to tighten guidance and expectations of doctors in terms of setting out a new duty for them and adding a new duty around those who witness such behaviour. We do publish our fitness to practice statistics every year. In fact, this year, that's normally in July, and this year we are wanting to make as much of that as we can and be as transparent as we can. So we'll reflect on that actually about how we can improve some of that. I am conscious that you have an FOI request which I think is being answered today, and I haven't seen the answer. But well, no, I think the legal deadline was today. But I know that is incoming. I mean, Anthony may have more to say on the numbers, but I would say, you know, we will always act where we think it is the right thing to do in relation to sexual misconduct. We, as I'm sure you've seen from the Royal College of Surgeons report, we don't always get the outcome we seek from tribunals, and obviously we're disappointed if we don't get the outcome we seek, but we recognise that the tribunal decision making operates independently from us, and we will appeal where we believe.
Just to move you on to that, so would you commit to publishing slightly more data on sexual harassment and misconduct places?
I can commit to thinking about what we can publish. I don't know, but without. I'd want to just sit down and think through what do we do? Can we pull this together in a more transparent way?
In terms of the high-level numbers that I was able to get after asking FOIs, there's nothing in there that couldn't have been in the public domain.
Can I defer to Anthony, but it's the person who pulls all of this data together?
So I think it's a good question, Josh, and I think we, on the back of your FOI request, realise that some of our data and the way we capture it is insufficiently clear. So that's the starting point. We need to make sure we can capture the data and then publish. So we will do that, thinking about what we may be able to publish in this space and be more transparent about it.
So Charlie, you said you take sexual harassment and misconduct incredibly seriously, so it's unacceptable. From my FOI, we know that between January 2018 and August 2025, 997 complaints linked to sexual assault were logged, but only 53 resulted in suspension or erasure. Is that good enough?
So, I'll probably defer to Anthony on the details, but of course, an allegation is not the same thing as reaching a conclusion where there is a clear fitness to practice action that needs to be taken. So I think it would be wrong to conflate a number of allegations made to us as being allegations that were all upheld. Certainly where
okay, but I mean, the scale is quite extraordinary. So I don't think that you're sitting in front of this committee and saying 94% of allegations are unfounded. No, and also if I kind of relate back to the Royal College, and this is kind of tricky territory because obviously all sexual misconduct and harassment is unacceptable, but there are varieties, and the Royal College of Surgeons report talks about moving from clumsy to creepy to criminal, and obviously the GMC, as we were talking about earlier, is an organisation that exists to make decisions about taking doctors' licences away, and there are other players like employers who perhaps operate at the more clumsy end of that spectrum. It's not simply it's putting other conditions in as well.
Yes. But I mean, but my point being that that the GMC is not the only organisation that takes action where these sorts of allegations are upheld in any degree whatsoever. But I don't know, Anthony, if you wanted to say any more on the numbers.
Well, really just about the process in which we operate, Josh. So it's a legal process. Where allegations are made, we take them seriously and we do consider them, but ultimately we have to prove that allegation to a certain standard by a tribunal.
And the standard civil
it's a civil standard,
so it's balance of probability.
On the balance of probability, absolutely.
So
correct.
you'd expect it to be much higher than sexual assault claims in the ordinary courts in GMC tribunals in terms of how many cases you take, right?
Yes. But I think the same challenges they face in terms of evidence, witnesses, and being able to prove that are the same challenges that we face. So I think we do prosecute those cases where we have the evidence and where they where we have witnesses who are willing to help us, because sometimes witnesses, although they were reported, don't then want to, quite rightly, put themselves through that process. So there are a number of factors that affect the success rate, which is why, as Charlie says, the numbers in, which we will always look at and look at seriously, and the numbers out don't necessarily match up.
So just to stick to that theme, in terms of my FOI requests, we found that 90% of complaints concluded with no formal sanction. But actually, when it comes to the ones that you prosecute, 2/3 of them do end up in a serious sanction. Does that suggest that you could perhaps prosecute more, and you should perhaps think about a lower threshold to how many you prosecute?
So the threshold we use, which we have to use to refer to a tribunal, is statutory. So it is whether or not there's a realistic prospect of proving it to the civil standard such that action will be required. So we don't set that in a sense. So we have to take that into account. So the seriousness and evidence before we go to a tribunal.
Are you doing anything to check that you're not filtering out too many cases too early?
Yes. So the PSA, who we mentioned before, our oversight body, do audits on our cases from time to time. We run internal and external audits on our cases and decisions to make sure that we're in the right space in terms of these decisions. And of course, we're challenged through judicial review and or appeals in some of these cases. So the sort of judiciary has an oversight on some of these cases.
Going back to Alex's points about interim orders, I'm going to bring up a case. The case is now that this doctor has been erased, but Dr. Emmanuel Hakim was a doctor who practiced with a chaperone who was a gynecologist. He practiced with a chaperone for a year after being arrested for a sexual offence. Does that seem like an appropriate interim measure?
Sorry, Josh. So he had an interim measure.
He had an interim measure, and he's since been erased, but he was allowed to practice for a year with just a chaperone. Does that seem appropriate for a gynecologist?
On the face of it, no, and I don't know the facts of that case, but I think the committee needs to understand we send the case to the Interim Orders Tribunal and we seek orders. We don't then make the decision, and we have no means of challenging a decision that we don't like at the Interim Orders Tribunal.
So another issue that comes up obviously is that, and we're thinking about the victims here, we talked about the long delays. There's also quite long delays for appeals, so the average appeal wait is 406 days. Could more be done to support victims through that process?
I think yes. I mean, we do a number of things, including working with victim support to support victims, but it is never going to be easy. And of course, the length of appeals time is not within our gift. So where we do decide to take an appeal, we make sure that the witnesses and victims are aware of that, but also then try and help them through what is a difficult process.
So my final question to Charlie, because it's more of a strategic one. We've got a high number of complaints that go nowhere, so 90% of sexual harassment complaints. We've got long delays, and the average appeal being 406 days. We've got inconsistent sanctions. We've got a lack of transparency. Do you think the GMC is doing enough to make sure that female patients are safe in doctors' offices?
So I think there's always more that we should be doing and challenging ourselves to do. And indeed, I think we have been doing things. So you talk about inconsistent sanctions. One of the things that was introduced in November was new sanctions banding guidance for medical practitioner tribunal panels. So you'll know that, because I think I'm on record as saying that we are concerned or have been concerned about the quality and consistency of some of that decision making. Those decisions aren't for us. The tribunal panel operates independently from the GMC, and that new sanction bandings guidance provides much clearer guidance for tribunal panels in terms of what the appropriate sanction is if they find impairment. The timing on appeals, I think, is a really tricky thing because we don't control the passage of time it takes from an appeal to that being scheduled with the High Court. That is just simply not something which, I mean, if there is any leverage that you can think of that I could use, I'd be absolutely wanting to embrace that. You know, it is a sad fact of the level of demand within the legal system that we face. As Anthony says, I think we could always be thinking about how much more support can we provide to victims. I think, just asking me the kind of broader question, taking a step back, the level of sexual misconduct we see in the medical workforce is staggering and should give us all real pause for thought. We have been collaborating with a range of organisations about how can we best address that. And my view on that is it's about getting upstream. It's about being able to take action before these terrible things are perpetrated on women.
I appreciate the getting upstream thing, but there is a high level of sexual harassment and offences in the
Yes, we need to do both.
We've got this problem of powerful men, and yet 90% of complaints go nowhere. So, can you be doing more? So,
we can always do more. As Anthony said, you know, the threshold for deciding when we investigate is a statutory threshold. But I would argue we're operating on all sides of this. We're operating to improve the quality and consistency of tribunal decision making. We're making sure through our own audits and through external people being involved that the decisions we're making about escalation of investigation and the sanctions we seek are appropriate. We're also produced much more stricter guidance for doctors in terms of what we produce in good medical practice. We've gone further than most in terms of introducing new duties for those who witness such behaviour. Our leadership and management guidance creates new duties as well for those in leadership and management positions, being obliged to speak up where they witness such behaviour. So we are trying to act on all of this, but I'm not in the least bit complacent. I think there's always more we should be challenging ourselves to think about what we can do.
Just a very brief supplementary follow-up kind of on that note. So my local acute hospital, you've placed conditions on their anaesthetics and training programme, and thank you very much for writing to sort of keep me updated on that. But the reason that you have attached conditions is mainly around concerns around misogyny, sexually inappropriate remarks and behaviour by consultants. Aggression was listed as well, a worry that they'd be learning improper practices, and reports that the consultants were repeatedly acting in a chaotic fashion. The response of the hospital trust was initially to remove the trainee anaesthetician doctors, sorry, I can't say that word, from that particular hospital. And the conditions that are placed on it are, again, that there will be no training programme running there until you're assured that certain conditions are met. However, it strikes me that the people that would have been engaging in these misogynistic, sexually inappropriate behaviours are the consultants at the hospital, and there doesn't appear to have been any kind of sanctions or any action taken against them. Now, that if I come at it from a patient safety kind of point of view, I'm a user of that hospital. My friends, my family, my constituents all use that hospital. What can you say to them, particularly if they're a female patient, that they will be safe under the care of these consultants who have been engaging in this behaviour?
So sadly, we do sometimes see, and there are a couple of hospitals where we've taken our enhanced monitoring powers in relation to training environments where we have had reports of racist and misogynistic behaviours. Where we do that, our first priority is to make sure that we're safeguarding trainees and patients in that particular department, which I believe we've done and acted swiftly to do. When we also find that, we will be separately, and this won't necessarily be within the public gaze, be having conversations with the responsible officer. That's normally the medical director in a hospital, and where there are allegations, sometimes those don't relate to individual doctors that are easily identifiable, so some of this data comes out of our national training survey. But we will be following that up through our outreach teams. Anthony mentioned them earlier. And that's a capacity that we've massively grown over the last decade. And through that, we have an individual relationship with every single responsible officer and medical director across the United Kingdom. And through that, we will be having conversations about individual doctors, where we've been able to identify them, where those sorts of unacceptable behaviours. And if that requires investigation, then we will take that forward. But we do not publish all of the details of live process until we've reached an outcome. And as we've been talking about before, we don't reach an instant outcome when we're investigating doctors under our fitness to practice rules.
Is really, if people have been engaging in this behaviour, will they be held accountable, rather than looking at a kind of how do we change the culture there, because people will have been perpetuating it, and thus far all that seems to have happened is the people that were victims of this kind of behaviour have been moved to an alternative hospital in the trust, and it doesn't necessarily look like people have paid for it.
This is probably I misspoke. So when I talked about responsible officer, it wasn't just about culture. Is because that responsible officer is the individual who will be making referrals of individual doctors to hold them to account. So we will be having the conversation both about that individual accountability and the culture questions within the trust. So we're doing both of those things at the same time. And I can assure you that we will not close our eyes to those questions about holding individual doctors to account where we are able to establish that they have been behaving in that sort of way.
Alex McIntyre, before we move on.
Interim orders tribunals and the fact they're independent and you go to them. Obviously, I think we all would agree in this room that sexual predators shouldn't be practising as doctors, and you'll recognise the point that the GMC has to play across the practices, because if someone's being reported in their NHS practice, it might not have come through to their private practice and other institutions. But I'm just struck by the thing you said about the fact that if the interim orders tribunal say we're not going to put any restrictions on, there's nothing that the GMC can then do. Because I mean, there's 2 points I'd ask. One is, you do have the right to appeal, don't you, to the High Court as the GMC if you don't agree with the interim orders tribunal, if you think there's been a mistake on the public point. You don't have any right to appeal.
Not on interim orders.
Not on interim orders. No. Secondly, what work is being undertaken by the GMC to actually get the standard of the representations that are being made in interim orders tribunals improved? Because clearly, if you've got somebody who is a sexual predator, surely that seems like a pretty slam dunk case for some restriction of their practice. So is it an issue that the GMCs aren't making the appropriate representations to the interim orders tribunal?
I don't think that's the issue, but in terms of QA and training, we use senior counsel, external counsel, not our in-house lawyers, to make it, and we do QA and training with them on what's expected, and we review the decisions, including what representation they've made, to make sure that they have presented the case in the best light and feedback as we need to.
But I think it also, if I may just very briefly, it also relates to the sanction banding point I made earlier. So what we're trying to do is to support the medical practitioner tribunal service in improving the quality and consistency of its decision making, particularly in cases where, like sexual misconduct, which is a specific conversation I've had with the new the new MPTS chair who arrived in post just a few weeks ago, because that should give the tribunals clearer lanes to operate within when thinking about the sanctions that they dish out when we come to them.
And will it remain the position that you still won't be able to appeal when the new legislation comes forward? Is that your understanding? So
we've never had a right of appeal on interim order tribunals. Yeah. We have at the moment a right of appeal on the final fitness to practice decisions that tribunals make. The right of appeal we currently have, the government has said it intends to remove when it legislates. As I said earlier, we believe we've always used that proportionately and appropriately, but we will continue to make our views known through the PSA, who will continue to have a right of appeal on that fitness to practice position, so that they're able to exercise that right of appeal should the government decide to proceed with removing the existing one.
Hamilton.
Good afternoon. My questions are related to the response to the maternity review. Let me start by saying failures in maternity services across the piece over many years has meant that many trusts have got into problems. And basically we had the Donna Ockenden, have I got that right? Ockenden, an independent review which was carried out. But yourselves at the GMC, you gave an apology last year, and you said, and I think the apology was in June last year, and what you said that the apology was to families for not responding quickly enough to the Ockenden review into maternity services. After that apology, what I'd like to ask you is, what were the lessons learned? Because yes, yourself and the NMC have given the apology. What were the lessons learned from that?
Sure. I might start and then hand over to Anthony, because Anthony's been spearheading our work, which goes exactly to your point. We've been engaging directly with the families affected in Nottingham, where Donna Ockenden is currently undertaking her review. We're also engaging with families in some of the other maternity trusts that Baroness Amos is looking at, and we're engaging with both Baroness Amos and other organisations about maternity services generally. But in terms of your specific question, we've been meeting families in Nottingham, and I think and I've met families myself personally in Nottingham, as has Anthony, and the feedback I received directly from those families is that we haven't been as good as I would like us to be at making ourselves visible to families and making our processes accessible to them. So if families find themselves in that terrible, tragic position where they've faced traumatic experiences as a result of unsafe and uncompassionate care, we need to make it as easy as possible for those families to raise concerns with us.
So just moving you on quickly, how have you started to do that?
So I'll start and head over to it. So we've been working with national charities to develop a range of materials. We've been working through our outreach team to engage with the registrants, and we've also been setting up a number of surgeries in Nottingham to engage directly with families and give them an opportunity to come in. But Anthony, you'll probably be able to give more chapter and verse.
You follow on.
Okay, so I think the starting point is, as you say, what's happened to this family should never have happened, and that's what we're trying to make sure we don't. So what has been really insightful for us on families is, as Charlie said, what they need. And it's not about the system, and it's not about the GMC, it's what they need. And what they said to us was, you need to come to us, and you need to hear our experience, but we don't want to keep repeating it to different bodies. So what we did is, we contacted the coroner, Donna Ockenden's team at the review, the police, and gathered as much information as we could. Then we set up meetings in Nottingham to meet with families where they could come and talk to us and the NMC once. We had the details, and they could then tell us what they wanted to go forward with.
So from what they've told you that they wanted to go forward with, what have you actually done?
So we have opened a number of inquiries and investigations.
So you've opened more inquiries?
Yes, okay. From meeting the families.
All right.
Obviously, as you know, Donna's review is not complete, so it's still ongoing.
It's this year's summer.
It is about June. So what she has given to us is about 312 case files late last year, where she's gathered some information from the families. So we're reviewing those, connecting the dots with the families we've met, and then we will consider those through our processes.
Just in terms of other things we've done, so we've been attending family days. Indeed, there was one just this last weekend that's gone. We've been holding family clinics in Nottingham throughout 2025 and into this year. We have been in direct contact with the affected families about developing an action plan, which we shared with them about improving communication. Can
I stop you there? Yeah. I get very frustrated, and I'll tell you why I get frustrated. The Ockenden review may have been the second to last review, because we did do one in the Health Select Committee, but I think there's been so many reviews over the years that for you to tell me you're still doing yet another inquiry, is there nothing that you have actually implemented?
So we're not doing any inquiry. We're working.
No, you've said you're doing further inquiries from the cases you've got from the families. Is that had I misheard that?
So our role is to consider whether or not the doctors involved in the care are fit to practice. That's our role. So we have received information from the families and from the review, which we are now considering and looking at to make sure that the doctors who they've complained about or have been referred to us are fit to practice. That's what we're doing. So it's not a review, it's actually working with the families.
I'm only going by your words. That's what I was told.
So we're reviewing the case files.
Right.
But the process we follow is whether or not that information that we now have suggests that that doctor is not fit to
You
practice.
see, I'm not an expert at this, and really, forgive me if I've misunderstood, but what you have said, you made an absolute apology, and you said from the GMC that you were going to look at lessons learned, and from the lessons learned, I thought some of the structure, some of the way you did things would change. And what I'm getting is you're looking at the individual cases now, and if the doctors have done something wrong, they'll be struck off. I don't know. I don't know what will happen. But from fundamentally, the reason this happened, it's because the structure, the way that things are dealt with is fundamentally wrong. So what have you done? Just one thing that you have done as an organisation to say, well, look, this wasn't going right, this could happen again. This is what we've done to ensure that this never happens again. And I'll hand it over to you, Anthony.
Okay. So what we have done is to work with the Trust and others on, as you say, the structural challenges there are. And as you rightly say, your committee identified exactly the same themes that we have, which is lack of leadership, interpersonal tensions, poor blame culture, lack of candor, etc. So the list goes on, and that applies across all these maternity sites, unfortunately. So what we have done is, and continue to do, is work with the Trust, the doctors, and with the NMC, with the CQC and others, to try and say, how do we, as you say, support better care going forward? What I was talking about was the individuals who have come to us, the lessons learned. So I was the one who issued the apology in June, and that apology was to the families for the way we had been engaging with them, which we changed, and that's what I tried to outline to you. So in terms of the structure...
Yes, so has anything changed, your structure, since last June? Because if it's happened before, can it not happen again?
Sadly, I think it can, but the changes I talk about are how we interact with families who come to us. That's what's within our control. We can't change the structures in a trust.
You can't change the structures in your organisation?
No, we're not...
No, I'm just asking. Tell me no.
So if I come the fitness to practice cases take on their own kind of form and structure in terms of approaching the questions about investigating whether doctors continue to be fit to practice, and that's what the 312 that Anthony was describing relates to. The questions about how we improve our engagement with families were very much in kind of in our minds as when we issued the apology, and we've made a series of steps to improve that, including holding family surgeries, clinics, etc. The broader question about how do we play our role in improving maternity services in the UK is a big exam question, and and I do believe we have a role in that. That isn't about our structures in terms of fitness to practice. It's about things like how do we use our data to better inform others about where things might be going wrong. And indeed, we initiated a data sharing process with the NMC and the CQC about 3 or 4 years ago, where we tried to pool all of our data in a shared data platform, because my view was we need to look at, if we can pool our data together, will we get better insight, better intelligence, better early warning, where we can anticipate where things are going wrong.
You know why I'm asking you? You're starting to hit the point. It's because if you go back to what Alex was saying and actually go back to some of what Josh was saying, you have got doctors that are there that, for whatever reason, their practice is not the best it could be. They have carried on practicing, not weeks, not months, but years after a case has been, something's gone in about them. You've got women on the other hand, or families that have been complaining about the level of treatment they've been getting. We've been getting report after report which has been backing them up. But in your structures, the way in which they are being examined, that does not seem to be changing in any way, so that we can give doctors that perhaps are not performing the best way they could, the training they need, or those very poor doctors that shouldn't be practicing, drum them out of the system a lot quicker. So
I respectfully disagree. I think we have made a lot of changes in how we engage with families, and made it easier for them to access our processes. We've also been working very hard as a part of a system level, because what happens with families is they are let down by a system of which the GMC is part, and we are part of a system that has failed families. And I'm clear about that. And that's why we have been having conversations and initiating conversations with organisations like the CQC and the NMC, bringing our data to the table. And indeed, when we did that, we were able to see, for example, some workforce metrics that were more indicative of future maternity problems. The question then is, what do you do with that? So I sat down just a few months ago with Mike Richards, who's chair of the Care Quality Commission, to say, let's have a better conversation together about all of that. I also sit on the National Quality Board just as of a couple of months ago, because I said to Mike Richards and Penny Dash, I think the GMC has a real role in contributing to improving healthcare, and particularly maternity care, where frankly we see too many tragedies continuing to happen and lessons that continue to not be learnt. Successive inquiries in maternity have come up with the same issues around culture, leadership and so on.
You have spoken to me, my time's up, but you have spoken to me for the last 8 to 10 minutes, and I've asked you, what have you done practically? What have you done to ensure that if we have doctors that are not performing, that we don't keep talking about it, we change the system, the structure, whatever you want to call it, to ensure that these doctors are not allowed to practice till they get the training they need, or perhaps lose their numbers for a while. I don't know what that is. And you've not been able to give me an answer that I feel I'm happy with. But on that note, I'm going to hand back to the chair, and others will be coming in with further questions. Thank you.
Thank you, Paula Hamilton. Jen Craft.
And if we could turn now to the issue of anti-Semitism in the NHS. And I would just like to first of all ask how you're engaging with Lord Mann's rapid review into tackling racism and anti-Semitism.
So I met Lord Mann just before Christmas with Anthony, and we've also written to Lord Mann, I think, on a couple of different occasions, both ahead of that meeting and immediately afterwards. We've also been engaging with the officials that are supporting Lord Mann. I don't know what he's concluding. I know that his report is due imminently, but I feel we've been able to set out very clearly and hopefully convincingly to him that we view any form of anti-Semitism or Islamophobia or other form of racism as unacceptable, and that we have zero tolerance of racism.
Your organisation has an expert knowledge of anti-Semitism, and what training has kind of been undertaken by some of your assessors in that regard?
So we've been doing a lot of training, and Anthony can say more because it's another programme that Anthony's leading for us. We have for a number of years been training all of our decision makers in fairness and bias in our processes, and specifically in relation to anti-Semitism. We invited the Community Security Trust and Antel Mama to come and meet with our decision makers. I think that was in early December, and that's something we intend to continue to repeat through the organisation. We've also invited the Community Security Trust and Antel Mama to come to our council meeting, that's our board meeting, next month, where they will be delivering the same training to the senior team, including both of us and indeed all of our council members.
But there's no one at the moment in the GMC who has expertise in anti-Semitism, would that be fair to say?
So this is probably where I turn to Anthony, because we have drawn on a lot of expert advice in dealing with those cases of anti-Semitism that have come into us, but I should probably hand to you at this point, Anthony.
So we have worked with Community Security Trust to enable our, as Charles said, decision makers gain more experience in it. We've also worked with the Jewish Medical Association and others in terms of understanding the concerns and how we might approach that. And we've worked with senior King's Counsel barristers who are expert in this field to ensure that, again, we're on top of what we need to be on top of in the law.
Are you confident as well that the MPTS have the understanding and expertise? And are you satisfied with the outcomes where you refer cases of anti-Semitism to them?
Shall I start? So that is, as you might not be surprised, something I talked about with Fiona Monk, the incoming MPTS chair, just in the week that she started her job earlier this month. We we haven't always achieved the outcomes we want in terms of some of the interim order tribunals we've had, where we've tried to temporarily take action against the doctor's licence while our investigation continues. And as we established earlier, we don't have a right of appeal on interim order tribunals, and on one or two of those we've had, with new evidence coming in, been able to take a further case to an interim order tribunal, ultimately being successful. I think you ask a really good question about do decision makers, whether they be at our end or the medical practitioner tribunal service, have specific skills and expertise and knowledge in relation to cases like anti-Semitism. I think you can make the same argument about sexual misconduct too, and that is part of a live conversation we're having with the MPTS. They operate independently from the GMC, so it's not for me to tell the MPTS what they need to be doing, but I do believe that those issues are actually well understood by the incoming chair, and I expect to could speak to her more about that in the coming weeks.
Have you taken steps to assure yourself that your internal kind of procedures and the things that have prompted the Mann review, that it doesn't really reflect an organisational weakness in how you handle cases of racism and anti-Semitism?
So I mean, we're always reflecting on whether or not we're doing all the things we should be doing. I mean, in relation to anti-Semitism specifically, we did have a big influx of cases after October 2023, and we wanted to make sure that in our handling of those cases we were bringing an expert and proper legal perspective to the way in which we made decisions about our fitness to practice cases, and indeed that's why, as Anthony said, we've used external legal counsel to help us with that. That did cause some delays with those cases initially, but I think that was probably the right thing to do in terms of ensuring that we had a consistent and more expert approach. As with all things relating to training, you should never view yourself as having reached the end of that road. I think any decision making is the function of a collection of human biases, and so we need to be constantly refreshing our training and making sure that we are bringing both an expert perspective in terms of issues like anti-Semitism, but also a perspective of understanding our own biases when we're faced with particular decision making. And we put a huge amount of effort into all of that at the GMC over recent years, because my view is we should be looking for bias in the expectation that it exists, rather than trying to find evidence that suggests it doesn't, if that makes sense to you. So this is a job that will never be complete. It's something that we need to continue to focus on.
Do you imagine that you will probably have to make significant changes following the Mann report in the way that you can handle these kind of investigations?
I really don't know. I mean, I think we had a conversation with Lord Mann that related not just to regulatory responsibilities, but the responsibilities that employers have. And remember, employers are the first line of defence when people are behaving in an offensive or racist way. I know that Lord Mann will be considering, are there changes to our underlying legislation that might be required. If the government decides it does want to go down that route, it will need to make decisions relatively quickly, given the process that I described earlier and the timetable for new legislation. And if that happened, that would be part of the consultation for legal change that the government would want to get out the door before purdah periods begin in Scotland and Wales. But I can't honestly right now give you a prediction of where he might land, because I just simply don't know.
What I would be interested in, I think, is a kind of bit of self-reflection. So speaking to people I know who would fall under your regulatory framework, so doctors, that kind of thing, their kind of feel on the way that the GMC has approached the scale of sort of anti-Semitism over the last couple of years has perhaps not been as robust or dynamic as it could have been. And given that, and it's not just the GMC, it's the wider regulatory bodies in the medical profession, so the PSA, the MPTS, but all the ones that regulate the various professions. Do you think that together among you have the ability to tackle anti-Semitism and racism at its root cause in the NHS, or do you expect that the Mann review will tell you things that you weren't expecting?
So tackling anti-Semitism as a root cause in the NHS goes well beyond a single professional regulator, because what we're talking about there is, sadly, a lot of beliefs and behaviours that permeate society, and I'm not trying to excuse the GMC from having a role to play. I mean, we do have a role to play, and part of that's about how we express our expectations of doctors' behaviour, and we're currently updating some guidance on religious beliefs, where I expect us to go into more detail around all of that. So we definitely have a role to play, but it is not for the GMC alone to have the responsibilities solely for rooting out racism in the NHS. We should all be ashamed of the level of racism that exists in the NHS, and the GMC, for absolute clarity, wants to play the biggest possible role it can in addressing that. But it's much more than us. There is always, in terms of the fitness to practice cases and the questions, a question about, are we being sufficiently pacey at dealing with those? Some of the questions that we talked about earlier. As I said, I think when we had a big influx of those cases arrive, we wanted to take an expert legal advice. We now have that, and we have that expertise, which I think has meant that going forward, we're much better able to move those cases at a level of pace.
So do you think, just to go back to the other regulatory bodies, do you think there exists the ability for coordination between you all to tackle this kind of significant issue? Or is that something that is a wider issue for someone else to perhaps answer?
So there is, and indeed, I meet with all of the other chief executives of regulatory bodies, and we have had explicit conversations about how are we each approaching questions of anti-Semitism, to what degree are there differences in our approach, and are those differences right, and should we be aiming for a consistent approach? Each of the regulators currently operates under a slightly different legal framework, which doesn't help in terms of consistency, but my view is always, particularly on issues like racism, that collaboration and alignment is always better than being misaligned and not collaborating, because if we collaborate and we're aligned, we have a much greater consistency in terms of the messaging we're putting out to our different registrant groups. We have much better ability to be saying exactly the same thing to our registrants as system regulators say to employers.
On why coordination is beneficial, and the question is, do you think it exists, and do you think the potential for that coordination to tackle these issues is there, or do you think more work needs to be done?
So we hosted a round table with all professional and system regulators last year, and imminently we will publish some joint regulatory principles, which I think is an admission that we do agree that there is more that we could be doing together. And I think what you will see when we publish those principles is that we have actually been working on precisely that exam question. There will still nonetheless be some differences in approach, because each organisation will use different definitional boundaries or whatever. But yes, I think there is always more to do, and I'm keen that we play our role in doing that.
There's a stakeholder list for that.
Yes, indeed.
Just to come down to those kind of definitions and that sort of work, where do you think there is a line to be drawn between opinion and obviously free speech of medical professionals, not just doctors, and where that actually plays into questions of fitness to practice?
Yeah. I'll probably hand over to Anthony on that one.
So I think freedom of speech doesn't cross into fitness practice. People have a right to be to free speech, and can be offensive in that. I think where it crosses over is when what they are saying or posting is objectively anti-Semitic or Islamophobic. And that's where we use the definitions that exist to help us make those judgments. But it is a judgment that then has to be made. But it doesn't necessarily cross over. I think there is a point at which political free speech, which is protected, is not a matter for fitness practice. We're quite clear doctors hold opinions and can hold opinions and share those opinions. But if you're objectively anti-Semitic and or Islamophobic, then we are interested in that. We need to consider that in the context. We also consider, even if it is not objectively anti-Semitic, whether it is offensive and or becoming of a professional, because you do hold that status in society. So are you upholding our standards? Are you behaving the way patients and the public would expect you to behave? And that is something we do look at as well.
And are these boundaries fairly clearly defined, or are they kind of constantly evolving, would you say, between where is something an opinion, where does it impact your ability to carry out your job as a medical professional?
I think you've hit on one of the challenges, because that is not necessarily static. I think that's why I use the word objectively anti-Semitic and objectively Islamophobic, because that is quite clear for everybody. But there are times when it might be on the line, and that's where we need to consider what I said as a secondary, which is actually, even if it is not objectively anti-Semitic, is it of the standard we would expect of a doctor?
Thank you. I'll leave it there.
Just a quick supplementary. When you say objectively Islamophobic, there isn't an accepted definition for Islamophobia, even in part. So what do you mean by objectively Islamophobic?
We use the dictionary definitions to help us with examples, and the APPG definition, because as you say, there isn't a universal example. So we use that, but it comes down to assessing the words used in the context, etc., etc.
Thank you very much. Becky Cooper.
Thank you, Chair. And just for the record, I have to declare an interest as I have a licence to practice on the GMC register. So I want to move us on. I appreciate we're coming to the end of the session. I'd like to focus your attention on registration of internationally qualified doctors. As I'm sure you're aware, we have a piece of legislation coming to Parliament next week, the Medical Training Prioritisation Bill. And Mr. Massey, if I can quote yourself, you've previously said it's vital that workforce policies don't inadvertently demoralise or drive out the talent on which our health services depend. Doctors who qualified outside of the UK make up 42% of those working in the UK. If we see even a small percentage increase in them leaving, our health services will end up with huge holes that they'll struggle to fill. And just to sort of put this in context, we are actually seeing larger numbers of internationally qualified doctors already leaving. So in 2024, 4,880 internationally qualified doctors left, a 26% increase compared to 2023's number. So my question, Mr. Massey, is do you think that this medical training bill risks having an adverse impact? And if so, how can that risk best be addressed?
So a couple of things, if I may. So, you said some of what I would say, so thank you for that. So I think it is entirely legitimate for government to set out plans about prioritisation in terms of allocation of training places with a prioritisation towards UK-trained doctors, because that is it costs a lot of money to train a doctor, both through medical school and their postgraduate training. And indeed, we said that in our evidence to the medical training review, phase 1, that the bottleneck in training needs to be addressed. We also said, though, that needs to be done with a really good understanding of the evidence base. So we know, for example, that in general practice, half of first-year trainees are doctors that qualified overseas, and in psychiatry, which is another specialty which has traditionally made more reliance on international medical graduates, 42% of trainees qualified overseas. So to your question, I think it is absolutely legitimate for government, but I think what needs to happen is that conversations about prioritising UK graduates need to be accompanied by clear statements that recognise and value the contribution that international medical graduates make in our NHS. And I think...
I'm so sorry, Mr. Massey, how do you see that working in practice? So when for example, we'll be making offers in 2026, so that will sort of have that prioritisation, and then obviously 27 onwards we'll be undertaking interviews where we'll prioritise. How do you see feasibly the balance between, as you say, legitimately saying that UK graduates cost a lot to train and therefore they should be prioritised, alongside balancing the need for international recruitment? How do you see that playing out?
So I think it's less about international recruitment, but about the doctors that are already working in the NHS. So it's that 42%.
So this is not new people coming in. This is existing.
Yeah. So I mean, we are seeing a number of international doctors joining our register. We have about 20,000 last year compared to about 8,000 coming out of UK medical schools. But the point you quoted earlier was me really saying we need to be really careful about those doctors that are already working in the UK, because there are 140,000 of them, and if only a small proportion of those doctors, who remember are highly mobile individuals, they have uprooted themselves and their lives and their families to come and work in the UK. If those doctors don't feel that they're getting adequate access to learning, development, training, that they're not being supported and valued in the workplace, there is a good chance that more of those doctors may leave. And indeed, in our data last year, we did see that there was an increase of 26% of overseas doctors leaving.
Okay,
So the question about what should government do about it?
So you're making a differentiation between people already in the National Health Service, perhaps who have qualified from international medical schools, and those people who might be coming afresh. So I think, just to perhaps assuage your concerns, but please tell me if this assuages them, in the bill, the priority list has UK medical graduates, it has persons in priority groups, of which, people who have right to remain, who, for example, who are from Ireland and, did most of their training here. There's a list of 4 countries where we've got a particular special relationship, but they also say persons who have completed or are currently on a relevant qualifying UK programme, and they go on to talk about people who have had substantive training in the National Health Service. Do you feel that that covers the concerns that you have around international recruits who have been in the NHS for some time?
So I think the focus on significant NHS experience, so for this year government's using visa status as a proxy for experience. For future years, I think the government has wisely left the door open in terms of defining what significant experience means, so that it can be much more nuanced about making sure that those hard to fill specialties get the doctors they need. But I'd say it's not just about the bill and formal postgraduate training. The other thing that we've been saying for some time is that we've seen a massive shift over recent years to many more doctors being locally employed and in SAS roles. And the significant growth of locally employed doctors has been fueled to a large extent by international migration. Those doctors have not historically had the access to the learning and development that I believe they should have. I think it should be much more attainable for doctors not in formal training to develop their clinical skills and experience and step into specialist roles in the future. Not at the cost to formal training, I need to be really clear. This is a very much a both-and position. So this is a particular position that we are advocating for with government in relation to the workforce plan that we expect in the spring, because I think that goes to this point around doctors feeling confident that they have the career progression and value and being valued in the workplace. And we know from our own research those are really important factors in determining doctors' decisions to stay in the UK.
Sure. No, absolutely. So just returning perhaps to my colleagues' queries, is there any risk with this medical training prioritisation bill? And we have been here before. This isn't the first time we've sort of looked at this issue around UK graduates. Is there any risk that you can see whereby we sort of end up with a 2-tier system, so to speak, where those specialties that are very hard to fill, and you've already alluded to a couple of them, are filled by international graduates, and we end up with a 2-tier system, and we inadvertently end up perpetuating a form of racism that nobody would like to see?
So I think it's too early to say, because I think the bill has only just landed in Parliament. There's quite a lot to be fleshed out in terms of what significant NHS experience means. Well,
it's on Tuesday, Mr. Massey.
It's all on Tuesday.
I know, but my point is, I don't think the bill is the only thing you should be looking at in answering that question. I think the question about what the offer is for the entirety of our medical workforce, whether they're in formal training or not, that is the missing bit of the equation in terms of reaching that judgment about do we have a 2-tier workforce.
Absolutely appreciate that, Mr. Massey. You'll appreciate that we're parliamentarians and we have to pass legislation to the best of our ability, and this is the bill that's in front of us. For the General Medical Council, are there any practical considerations with this bill that you would like to make us aware of?
No, I don't think so. I think I've made all the points I would make to, and have made to senior officials and ministers.
Excellent. If I could just, before we move off from the bill, one small point, and it is something that's of interest to me because it is my specialty. So the bill actually alludes specifically to public health as being an area that's exempt from this legislation. So UK Specialty Training Programme means a programme of training required for or leading towards the award of a CCT, Certificate of Completion of Training, but does not include a programme wholly in the area of public health. And the reason, as I understand that, is because there are medics and non-medics that go through this specialty area. Can you foresee any issues arising as a result of this exemption?
Not off the top of my head. And I think that the other point is we need to make sure we are continuing to make other routes to a CCT or to come into the specialist register attainable. And what I mean by that is that people who get on our specialist register aren't just those doctors going through formal postgraduate training programmes. And one of the bits of work we've been doing with all Royal Colleges and faculties has been to make sure that we're really clear about the kind of the criteria that need to be assessed in terms of the skills and experience that make it easier for those doctors to demonstrate they have those skills and experience to join the specialist register. But I don't see anything specific in relation to public health that I see as being immediately worrisome in terms of the bill.
Thank you, that's clear. And just very quickly before we finish, I just want to move on to education, training and development, which is a large area, but I will précis it down. So obviously we hear a lot, and I hear a lot from colleagues about burnout, about people dissatisfied with their day-to-day work, about all sorts of issues, and your GMC survey in 2024, 74% of those responding said that they were likely to make a change to their careers in the next 12 months, and that included 19% who indicated plans to leave the UK, so perhaps that gives us pause for thought with our bill next Tuesday as well. But my question for yourselves is, based on the fact that we're now in this period of the NHS 10-year strategy, we're looking for this 10-year workforce plan that's coming forward. So what considerations arising from your insights into education, training and retention should be foremost in our minds as we look at this 10-year workforce plan?
Okay, so I'll do those in reverse order if I may.
Sure.
So start with retention. So for a number of years we've been publishing our data about doctors' experience in the workplace, and we use that to hold a mirror up, and we've reported high levels of burnout, high levels of workload, which particularly dipped following the pandemic. And last year's report actually showed some gradual improvement in some of those data, but many doctors face real challenges and struggle to provide the patient care that ultimately is what drives us. So we've tried to use those reports, that data, that insight, to have bigger conversations about inclusive working environments. I believe the commitment in the 10-year plan to introduce staffing standards is really important and something we should all put our shoulder behind.
And so, just to be clear, Mr. Massey, there are no staffing standards currently?
So the 10-year plan wanted... I hope most employers will think about staffing standards and well-being of their workforce. What the 10-year plan said, it wanted to introduce kind of much more hardwired staffing standards, so much more consistency of data, more accountability for boards, that threaded through regulation and system regulation.
No. So it's fair to say the standards are variable at the moment?
Yeah, and I'm a big fan of that because I think standards are variable, and I don't think employers always put as much intention on creating inclusive, supportive workplaces as they should, and I do believe that is absolutely fundamental to those questions around retention.
And I think, can I just ask you to specifically to consider GPs? You mentioned GPs earlier. In terms of making that a career choice that is more appealing, how does the GMC sort of consider its role in sort of building up the education and training and support available to newly qualified GPs? So
in last year's report, we specifically talked about the challenges faced within general practice, and 44% of GPs were struggling with workload. 60% found it hard to provide sufficient care to patients at least once a week. That was much higher than for other specialties.
Yep.
So it's not for us to determine the government's plans in terms of GP numbers, the wider workforce in primary care, but we do use our data to enable people to reach those conclusions.
Yeah. So would you say it's fair enough, Mr. Massey, to say that from your data there should be more GPs in primary care?
I think it's a bit more complicated than that because it's about a much broader workforce that work within primary care. Primary care now looks very different than it did a decade ago in terms of the range of healthcare professionals. So I think it'd be wrong for, even though I'm the regulator of doctors, to say the answer is X thousand more GPs.
I appreciate that. However, if we're moving from hospital to community, and at the moment, as you know, ICBs are getting ready to be the strategic commissioner, and the ICBs are very much looking at primary care to be their sort of lead provider. Would you not say that that is additional burden on general practitioners and therefore increasing either the resources available to them or the numbers that are there to be able to do the work is not an unfair?
So I think to be fair to successive governments, they've put a lot of effort into getting more GP training places, more GPs in. I think the problem is the leaky bucket at the other end. So I think the problem we've got is that the kind of workforce pressures that we've been discussing and the well-being issues and burnout is driving too many GPs out of practice the other end. So this is where I come back to those questions about addressing working environments and workplaces, making sure that people feel properly valued, making sure that doctors have the time to do the things that they became doctors to do, to provide patient care. So for me, it's a much more of an issue about attrition and retention, and that's why, I mean, you mentioned earlier data about doctors saying they would leave. We saw the number of doctors saying they were taking hard steps to leave the profession. That means applying for a job or downloading application forms, double from 7% to 15% between 21 and 24.
Absolutely. So this is not a new problem. I appreciate we had a pandemic and that was very stressful for frontline healthcare professionals alongside the rest of us. But this is not particularly a new problem. So why have these issues that I think you've rightly outlined not been addressed previously?
So I think that's a complicated and difficult question. I think, sadly, working environments are not consistently good, whether in primary care or secondary care. I think it's much harder to get a handle of that in primary care because, by definition, there are many, many more employers.
But I think there is consistency in what general practitioners are saying, and it's been pretty consistent for a number of years as the pressures have increased. So why are we at essentially with 2026 and we are saying the same things, and the definition of insanity is saying the same thing, they're expecting a different outcome? Nothing appears to have changed. In your role as a GMC, you speak to a lot of clinicians. Why do you think it has not been addressed?
So I think the issues around well-being and workload and work environment in general practice have become significantly worse since the pandemic. I think the pandemic has driven some massive changes in the way in which general practitioners work and the way in which primary care is delivered in this country. I think many of those changes have been positive, but I do know that from talking to GPs that too many of them feel that the only way that they can survive, and we see this in our data, is by reducing their hours in order to cope.
And is that burnout of clinicians, or is that changing expectations, or is that under-resourcing of primary care, or all three?
I think there are going to be elements of all of those factors that I think we need to take account of. And I think, I mean, I appreciate being asked the question about what's the reason, what's the solution, but I think it is complicated, and I think there are some structural issues in relation to primary care. We know that there are far fewer GPs who want to become GP partners. I think that raises questions about the structure and funding for primary care. They're not issues that the GMC has particular expertise.
No, I appreciate that, but as a regulator, you do sort of...
As a regulator, I'm worried in what I'm seeing in terms of that data, and I'm worried that general practice has consistently come out of our data as one of the most hard-pressed specialties.
Sure, and there is stuff around discrimination, but I think we're out of time, aren't we? Yeah, absolutely. Thank you.
Thank you so much again for coming and bearing with us while we had votes. You waited very patiently. Thank you to the audience and everyone here.